So let's start with GIT now. And I want to tell you that in the last few years, there's been a resurgence of questions which are being asked from GIT. There was a period of 2 to 3 years where lots and lots of general surgery questions were being asked. But now again, the examiners are moving back to GIT. And the bulk of GIT questions are asked from esophagus and stomach. Of course, there are other modules also like biliary system, gallbladder, bowel obstruction. So I'll mention those topics, but esophagus and stomach are very, very important. So in esophagus, before we talk about the esophageal disorders, let's talk about the surgical anatomy, because a lot of points which I discuss here would be relevant to the conditions which we discuss later on. Now, you know that esophagus is a muscular tube, and this muscular tube arises at the level of C6. So C6 is your pharyngo-esophageal junction. This is C6, this is the pharyngo-esophageal junction where the esophagus starts. So this is the pharyngo-esophageal junction which is there, and this is where the esophagus starts and it goes down through the thoracic cavity and then into the abdomen. So this is the esophagus which is going down, and it finally pierces the diaphragm and it joins with the stomach. Pierces the diaphragm and joins with the stomach. So it pierces the diaphragm at the level of T10. It pierces the diaphragm at the level of T10. I'll tell you a mnemonic later on how to remember the diaphragmatic openings as well. Now, when we do upper GI endoscopy, and I'm going to share a video with you soon. So when we do upper GI endoscopy, the distances are always measured from the upper incisor. So the gastroenterologist measures the distances from the upper incisor. And when they measure the distances from the upper incisor, they come across 3 constrictions in the esophagus. Right? In anatomy, you might have been taught about 4 constrictions, but when we do endoscopy, there are 3 constrictions, and I'll just tell you about them. The first constriction is at 15 centimeters from the upper incisor, and this is your pharyngoesophageal junction. You need to know that the pharyngoesophageal junction is the narrowest portion of the GIT. This is the narrowest portion of GIT, and the diameter of the esophagus here is 14 millimeters. Is 14 millimeters, which is the narrowest, and I'll just tell you the significance of this being the narrowest portion of GIT. The other constrictions are when the arch of aorta and the left mainstem bronchus cross the esophagus. Now in anatomy, these are 2 separate constrictions, but when we do endoscopy, they are counted as one, and this is 25 centimeters from the upper incisor. This is 25 centimeters from the upper incisor. And the third constriction which we come across is 40 centimeters from the upper incisor, and this is where the esophagus pierces the diaphragm. This is where it pierces the diaphragm, and at the arch of aorta and the at the crossing of the left mainstem bronchus, the diameter is around 15 to 17 millimeters, and here it is 16 to 18 millimeters at the level of the diaphragm. So you can see that the narrowest portion is the pharyngoesophageal junction. So the narrowest portion is the pharyngoesophageal junction. Now there are two points which you need to remember here. One point is that this is the site of impaction. This is the site of impaction of foreign bodies. So if a child ingests a foreign body, it will usually get impacted here. And I'll tell you how to manage foreign bodies. We'll discuss that topic in some time. And the second is, this is also the most common site. This is also the most common site where iatrogenic perforations can occur while doing endoscopies. So iatrogenic means while doing endoscopy, there can be a perforation. So iatrogenic perforations can occur at this site. So these are the 2 points of significance of the C6 being the narrowest portion of the GIT. Now, before we move forward, I just want to show you a small clip of normal upper GI endoscopy so that you can appreciate that these constrictions are actually seen when endoscopy is being done and what are the various structures which we see when we do endoscopy. So this is a video of normal upper GI endoscopy which I wanted to show to you so that you understand the problems later on. You can see, you have seen the larynx, the postcricoid region, and now the gastroenterologist is entering the esophagus. So you can see the esophageal mucosa, and he's entered the esophagus, and as he goes down gradually, now you will see a change in the mucosal lining, and that is the GE junction, and now we've entered the stomach. After the stomach, you look above, so you can do a J maneuver and you can see at the fundus, and then you enter into the duodenum. You can see here we've entered into the duodenum. This is D1 and D2. And after inspecting till D2, that is when we are going to start coming out. We will remove our probe and we'll come out after doing an upper GI endoscopy. So like I told you, there are various diaphragmatic openings, and there's a simple mnemonic which I remembered when I was preparing for my USMLE. I just want to share it with you how to remember the diaphragmatic openings. So that mnemonic is I ate 10 eggs. I ate 10 eggs at 12. So this can help you remember the diaphragmatic openings. So it is IVC and the phrenic nerve at T8. It is the IVC and phrenic nerve at T8. At T10, it is the esophagus, vagus, and the left gastric artery. It is the esophagus, vagus, and the left gastric artery. This is at T10. And at T12, you have the aorta and the thoracic duct. You have the aorta and the thoracic duct which pierce the diaphragm at the level of T12. Now the next point in the surgical anatomy which you should know about are the two sphincters. So the next thing which you need to know in the surgical anatomy is regarding the blood supply of the esophagus. And the blood supply of the esophagus is segmental in nature. That means the upper 1/3 has separate blood supply, the middle 1/3 has separate blood supply, and lower 1/3 has separate blood supply. The upper 1/3, the arterial supply, are the inferior thyroid arteries, and it drains into the inferior thyroid veins as well. The middle part of the esophagus, that means the thoracic esophagus, that will get its supply from the descending thoracic aorta and the bronchial arteries, and it drains into the azygous vein. And the lower part of the esophagus, left gastric artery is the one which supplies it, and it drains into the left gastric vein. And these two have a lot of clinical significance. So left gastric artery being the supply of the lower 1/3 of the esophagus is important, because in the lower 1/3 of the esophagus, there can be a condition known as a Mallory-Weiss tear. This we'll talk about in the upper GI hemorrhage module, Mallory-Weiss tear. And this Mallory-Weiss tear can give rise to upper GI hemorrhage. This can give rise to upper GI hemorrhage. And there has been a question which has been asked, that which is the vessel which is responsible for this bleeding? And the correct answer there is left gastric artery. This has been asked multiple times. So left gastric artery is the one which is responsible for Mallory-Weiss tear, which can occur in the lower part of the esophagus. The left gastric vein, the significance of the left gastric vein is that this left gastric vein will then ultimately join the portal vein, join the portal circulation, and it is going to go into the liver. And this is how metastasis from esophageal cancer reaches liver. And liver is the most common site for metastasis from esophageal cancers. And it's through the left gastric vein, it goes into the portal circulation, and that's where it goes into the liver. And of course, the left gastric vein also becomes involved in patients with portal hypertension. This lower part, in patients with portal hypertension, the lower part can be a site for portosystemic shunts, and varices can form. There can be portosystemic shunts and varices can form, and varices can also give rise to upper GI hemorrhage, which I've covered in the upper GI hemorrhage module. So this was regarding the blood supply of the esophagus. The next thing is regarding the esophageal sphincters. So there are two sphincters in the esophagus. We know there is an upper esophageal sphincter and there is a lower esophageal sphincter. So the upper esophageal sphincter is both an anatomical and a physiological entity. Now, what exactly does that mean? So you need to understand that any anatomical sphincter is one where there is actual narrowing. So anatomical sphincters are ones where there is actual narrowing, whereas a physiological sphincter is an area of high pressure. Right? A physiological sphincter is an area of high pressure. So the lower esophageal sphincter is only a physiological entity. That means only a zone of high pressure. And the pressure in the lower esophageal sphincter is 8 to 25 millimeters of mercury. Whereas the upper esophageal sphincter is both an anatomical and a physiological entity. And it is formed by two fibers of the inferior constrictor muscle. You have the thyropharyngeus and the cricopharyngeus. These are parts of the inferior constrictor muscle. and this is for what forms the sphincter. Where thyropharyngeus, you have oblique muscle fibers. Thyropharyngeus, you have oblique muscle fibers, and cricopharyngeus, you have horizontal muscle fibers. So this purple one is the thyropharyngeus, and the brown one is the cricopharyngeus, which forms the upper esophageal sphincter. Now you can see here that there is a potential space between these fibers, and this potential space is known as the Killian's dehiscence, right? This potential space is known as the Killian's dehiscence. This has been asked many times in the exam, and you know that through the Killian's dehiscence, what comes out through the Killian's dehiscence? Through the Killian's dehiscence comes out a Zenker's diverticulum, which is a very important topic and which we'll talk about in detail later on. So that is the surgical importance of the upper esophageal sphincter. The lower esophageal sphincter, like I told you, it's only a physiological entity. Now, as you're watching the video, I assume most of you are not eating or drinking anything. So in all of us, the lower esophageal sphincter is in a tonic state of contraction. But if you are sipping your tea or munching something, then when you eat when that food reaches the lower esophageal sphincter, the lower esophageal sphincter relaxes, right? It lets the food or the liquid pass through and then it contracts again, right? So mostly in the resting state, it is in a tonic state of contraction in most of us. Now, there are two problems which can occur with the lower esophageal sphincter, and the two problems are that if the lower esophageal sphincter relaxes too frequently, in some patients, it relaxes too frequently, right? And if it relaxes too frequently, it can give rise to an entity known as GERD, gastroesophageal reflux disease. So gastroesophageal reflux disease, which is very common, and we'll talk about this in great detail because lots of questions are asked from gastroesophageal reflux disease. The other problem is if it does not relax, then what is going to happen? So if it does not relax, then it gives rise to a condition known as achalasia. Achalasia cardia is a motility disorder of the esophagus where the lower esophageal sphincter does not relax. So this was the surgical importance of knowing about the esophageal sphincters as well. Now there's a table which is given in the latest Sebastian which I wanted to highlight because there are certain values and these are frequently asked in the SS exam and the INI-CET exam sometimes. The upper esophageal sphincter, the total length of the upper esophageal sphincter is 4 to 5 centimeters. The resting pressure is 60 millimeters of mercury. The relaxation time is 0.58 seconds and the residual pressure is 0.7 to 3.7 millimeters of mercury. So as far as your NEET PG goes, just remember the length is 4 to 5 centimeters and the resting pressure is 60 millimeters of mercury. The lower esophageal sphincter, on the other hand, the total length is again 3 to 5 centimeters. Very importantly, abdominal length is 2 to 4 centimeters. And this is what prevents GERD. We'll talk about this. I'll explain you how this prevents GERD, this intra-abdominal length. The resting pressure is 6 to 26 millimeters of mercury. The relaxation time is 8.4 seconds and the residual pressure is 3 millimeters of mercury. Now, another point which I want you to know is that in the esophagus, if we talk about the esophagus, the lymphatics in the esophagus, they lie in the submucosa, right? They lie in the submucosa and they run longitudinally. And what is the significance of knowing that these lymphatics run longitudinally? Well, this can give rise to skip lesions or skip metastasis in cancers. Because of this longitudinal spread, there can be skip lesions. And that is why when I tell you about esophagectomy, that is when I tell you about esophagectomy in esophageal cancers, I will tell you that we take a 10 centimeter proximal margin. That is the highest in any cancer in the body. We take a 10 centimeter proximal margin because we don't want these skip lesions to occur later on. Also, you need to know that the esophagus lacks serosa. The outermost covering, the serosa, is not there in the esophagus. And the strongest layer of the esophagus is the submucosa. The strongest layer of the esophagus is the submucosa. You know this question has been asked in bowel anastomosis as well, where they've asked you what is the strongest layer in bowel anastomosis. There also the answer is submucosa. This I've covered in the suturing module. Moving on to the peristalsis which are seen in the esophagus. So esophagus, there are three types of peristalsis which are seen. Primary peristalsis is when the food reaches the esophagus. If you drink or eat something, the food reaches the esophagus and it is a propulsive wave which pushes food down. That is primary peristalsis, when food reaches the esophagus. Now, in majority of us, the primary peristalsis is enough to push food down. But sometimes, if primary peristalsis fails to push food down, then secondary peristalsis will occur. And secondary peristalsis is also a propulsive wave. Secondary peristalsis is also a propulsive wave. Tertiary peristalsis is a non-propulsive wave and it usually occurs in between meals. It occurs in between meals and it is non-propulsive in nature. Now, it has been seen that in elderly patients, the incidence of tertiary peristalsis increases. And this condition is known as press by esophagus. Right? This increase in tertiary peristalsis in elderly patients. So these were the points which were important in the surgical anatomy of esophagus. Now we'll start with the individual problems, and the first problem which I want to talk about is a foreign body in the esophagus. The reason why I want to talk about this is because in the last couple of years there have been two questions which have been asked regarding this condition. So mischievous children, they keep on putting things in their mouth and they can either swallow them or they can swallow them and it can go into the esophagus or it can go into the respiratory passage. Now, how do we differentiate whether it has gone into the esophagus or it has gone into the trachea? So obviously, first we have to look at the symptoms. So if it has gone into the esophagus, then the child will present with dysphagia. There can be pain as well. Whereas if it has gone in the trachea, if it is gone in the trachea, the child can have a stridor. Child will have breathing difficulty. So the first thing which you should look out for in the clinical question is whether they're complaining of dysphagia or they're complaining of breathing difficulty. The next test obviously is to carry out an X-ray. And when we do an X-ray in these patients, we will see that the coin is lying in the coronal plane. It lies in the coronal plane in the esophagus, whereas in the trachea it lies in the sagittal plane. Obviously, this sounds a bit confusing. A simpler way is to do a lateral film. And when we do a lateral film in these patients, you know that trachea is anterior and esophagus is posterior. So if this is the trachea, so you will see an air shadow in front, and you will see the esophagus behind, and you can see the foreign body inside the esophagus. On the lateral view. So it will be the trachea is anterior, whereas esophagus is posterior. And that is how we can get to know whether it's in the trachea or it's in the esophagus. So you can see in this image, you can see a foreign body. This was a child who had swallowed a coin and it was there in the esophagus. Now, how do we manage esophageal foreign bodies? So if there is a foreign body in the esophagus, if the child is asymptomatic, and the foreign body has gone beyond C6. C6 we know was the pharyngoesophageal junction, which was the narrowest portion of the GIT. If it has gone beyond the pharyngoesophageal junction, patient is asymptomatic, then in these patients we just recommend observation. we just do observation. In some patients, we do serial x-rays, where we might repeat an x-ray after a day or two to see if the coin is moving distally or not. And we just ask the mother to monitor the stools to see whether the foreign body has been passed or not. On the other hand, if the coin is impacted at C6, or if the patient is symptomatic, in a lot of pain, then we need to carry out endoscopic removal of these coins. Endoscopic removal of these foreign bodies need to be done. Now, one exception to this rule is if the child swallows a button battery. These button batteries are very dangerous. And I have a young child at home, so I know how scared I am when they're playing with their toys, which is why most of the toys now, they have a screw at that area so that they can't open it and remove those button batteries. So if button batteries are swallowed, then all button batteries need to be removed. Because these can they can disintegrate and they can cause perforation. So we don't want that. That is why all button batteries, even if they've gone beyond C6, they should be endoscopically removed. So this was regarding foreign bodies in the esophagus. The next thing is regarding corrosive esophageal injuries. And corrosive esophageal injuries, I just want to tell you an instance because I never forget this case. I had a junior in my college at Safdarjung, and his brother was a foreign medical graduate. He was in Russia at that time. And he had gone to a bar to party with his friends, and there were shot glasses which were kept there. So he thought it is just a regular shot, and he just picked up one and he took that shot. But actually, the bar person had kept acid to clean some of the counters, and by mistake he drank that acid and he had an entire stricture of the esophagus, and it took him a very long time and multiple procedures to get better. So I never forget that case, which is why you should be very careful when you're dealing with acid or alkali substances. So corrosive injury can either be alkali injury or it can be acid injury. Alkalis penetrate deeper. And they cause more damage in the esophagus. They penetrate deeper and they cause more damage in the esophagus. And they penetrate deeper because of saponification. They cause saponification and they can penetrate into the deeper structures. Acid on the other hand causes coagulation and fibrosis. So does not penetrate deep. Does not penetrate as deep as alkalis would. But a peculiar thing about acids is that they induce pylorospasm. So when they induce pylorospasm, this acid remains in the stomach and therefore it leads to increased gastric damage. So more gastric damage is seen with acid injuries as compared to alkali injuries. So that is something which you should know about. Now, whenever you encounter such a patient or when this patient comes to the emergency, there are certain things which we need to be careful about. And in the management of corrosive injuries, you should know that whenever such patients would come, we first have to give IV fluids, resuscitate these patients, take care of their pain, and never blindly insert a nasogastric or an orogastric tube, because blind insertion of these nasogastric or orogastric tubes can give rise to perforation. So management of these patients, we have to give IV fluids in these patients. Nasogastric tubes should not be inserted blindly because they can lead to perforation. There is no role of prophylactic antibiotics. This is written in Bailey that there's no role of prophylactic antibiotics. If there's an infection, you give antibiotics. Otherwise, there's no role of prophylactic antibiotics. Very important is once this patient is stable, you will do an early skilled endoscopy. Early skilled endoscopy is the most important thing to do in these patients. to assess the extent of damage, and this should be done within 48 hours. This should be done within 48 hours because it is very clearly written in Sebastian and Bailey that after 48 hours, the chances of perforation will increase. So you will do this early skilled endoscopy within 48 hours. Also remember, there is no role of steroids in patients with acid or alkali injury. There is no role of steroids in these patients. Now, what happens is when this acid or alkali injury happens, you can see here, you can see in this barium that ultimately a stricture will form, right? A stricture will form in the long run. And the long-term management of these patients is to manage this stricture which is formed in the esophagus. There is also a grading of corrosive injuries, and this is called the Zargar. This is called the Zargar classification of corrosive injuries, and this basically tells us what is the extent of injury, also has prognostic implications. So normal endoscopic findings are grade 0. Superficial edema or erythema is 1. If there's mucosal or submucosal ulceration, it is 2. If there's transmural ulceration with necrosis, it is grade 3, and a perforation is grade 4. So again, those who are preparing for the INI CET exam and the SS exams, you should know the details. Otherwise, for the NEET PG exam, just remember that Zargar grading is there for corrosive injuries. That is enough. Now, ultimately, I told you that strictures will form in these patients, and we have to manage these strictures. And how do we manage these strictures? So management of these strictures, they can either be dilated, so dilatation can be done in these patients, regular dilatations, or if it is a long stricture, if it is a long complete stricture, then we need to carry out an esophagectomy as well. Then we need to carry out an esophagectomy in these patients as well. And we will talk about later that when we cut the esophagus, we need to replace the esophagus, right? We can't just leave gap in between the two ends. So to replace the esophagus, we commonly use the gastric tube, we use the stomach. But here the stomach is already affected with acid, right? So I can't use the stomach. So in patients with acid-alkali injury, the esophageal replacement in these patients is usually colon or jejunum. We don't use stomach if it is affected. Whereas when we talk about cancer, we will talk about that in cancer, stomach tube is the best esophageal replacement. So this was regarding corrosive injuries, and I want you to remember early skilled endoscopy. That question was asked in the NEET exam a couple of years back. The next condition which I want to discuss is congenital tracheoesophageal fistulae. Now, this is a congenital problem. So, these congenital tracheoesophageal fistulae, there can be various types. And what are the types? Let's talk about them. So, type A is when there is atresia. A is atresia. Atresia, you can see that the esophageal ends are not communicating with each other. One end is here, other end is here. There is some daylight between the two ends. So this is esophageal atresia, that is type A. Type B is when the upper part of the esophagus, the proximal part of the esophagus has a fistulous communication with the trachea, but the distal part is blind ending. Distal part. That is type B. Type C is the most common, and this question has been asked multiple times. Type C is the most common, and type C is when the proximal end is blind ending, but the distal end communicates with the trachea. That is type C. That is the most common. Type D is when both the ends communicate with the trachea. That is type D. Both ends communicate with the trachea. Type E is also very important. This question has been asked in the exam. Type E is when the esophagus is patent. You have a patent esophagus, but you just have a fistulous communication with the trachea. And if you see here, this forms, if you look at this orientation, this is also known as the H type. So where you have a fistulous communication, this is also known as H type of tracheoesophageal fistulas. You also have a type F, Type F is when there is just esophageal stenosis. So these are the various types. I want you to know about type C, which is the most common, and I want you to note about type H, where the esophagus is patent and there's just a fistulous communication. Now, certain points regarding tracheoesophageal fistulas which you should know, that NMYC gene has been linked with tracheoesophageal fistulae. So this is given in Bailey and Sebastian. You should know this NMYC gene is linked with it. Now, when do we suspect that there is a tracheoesophageal fistula? How do we suspect it? So the first thing which you should know, that mothers who are carrying children with tracheoesophageal fistulae, polyhydramnios can be there. There can be polyhydramnios in these patients. Of course, in the prenatal scans, sometimes you can figure out abnormalities, and prenatal scans can also tell you about these problems. But when the child is born, what are the features, what are the clinical symptoms which one should be aware of? So I'm sure as interns, you all would have seen deliveries happening, or you would have taken deliveries yourself as well. And whenever a child is born, the first thing which you do is you wrap the child and you suction the oral cavity, right? You suction the oral cavity and then you check whether the anal opening is patent or not. So that's what we do. Now, there can be certain children where there can be excessive secretions in the oral cavity, right? So if you have excessive secretions, or there is drooling of saliva, where saliva is just dribbling out of the mouth, then we should suspect that these patients might have some problem. And you know that this is the proximal end of the esophagus, this is the distal end, supposing we are talking about this orientation. Now, because the esophagus is not patent, that is why all the secretions are coming out through the mouth. And when there's excessive secretions, what we will do is, then we will try to insert, you will see that the pediatrician tries to insert a orogastric tube, right? We try to insert an orogastric tube so that we can take care of these secretions. But what is going to happen when you insert this orogastric tube in this child? If I've inserted this orogastric tube will not go down. It will coil up. It will coil up inside the esophagus, right? So this orogastric tube coils up. Coiling of the tube is another indicator that the child might be having a tracheoesophageal fistula, or esophageal atresia might be there. So these are the points which will hint towards a tracheoesophageal fistula. Of course, these patients can also have respiratory distress, because if there is a fistula, all these secretions are going into the trachea as well. So there can be respiratory distress in these children as well. Now, how do we confirm the diagnosis? So to confirm the diagnosis, how do we confirm the diagnosis? We will carry out a contrast study. We are going to put in a tube just in the mouth, and we will do a contrast study which will delineate the fistulous tract to us and will tell us which anatomy are we dealing with. So for this contrast study, the dye which is preferred is known as iohexol, is preferred over dinosil. And this has been asked in the exam, that iohexol is preferred over dinosil. This was asked in the All India exam around 4 years back. Now, this is going to delineate the type of anatomy which we are dealing with. Another indicator is that when we do an X-ray in these patients, and if you see, if gastric air is seen, if gastric air bubble is seen, or fundal air bubble is present, then that signifies two things for me. What does it signify? Then that signifies either esophagus is patent, or the distal end is communicating with the trachea, right? That is how air will reach into the stomach. So these are the things which we can get to know from the X-ray. Another question which has been asked in the exam is that for the H type, this was asked in the PGI exam 4 years back. For the H type, what is the investigation of choice? So for the H type, the investigation of choice is a combined tracheoesophagoscopy. Is a combined tracheoesophagoscopy, and this will tell me that the esophagus is patent and there is a fissureless communication between the esophagus and the trachea. Okay, so these are the clinical features which I've already discussed you. I've told you about the diagnosis, that the contrast study iohexol better than Dinosil, and I've told you that for H type it is combined tracheoesophagoscopy. Now, once we've confirmed the diagnosis that there is a tracheoesophageal fistula, we always should rule out other congenital anomalies. Okay, so in a child, this is a dictum that if you find one congenital anomaly, you always search for other congenital anomalies. And what is the very popular mnemonic to remember these congenital anomalies? This mnemonic is known as VACTOR-L. And this I've covered at other places as well. This you should remember, VACTOR-L, where V is for vertebral defects, A is for anorectal malformations, C is for cardiac abnormalities. Cardiac abnormalities are the most common congenital abnormalities seen in children. So C, cardiac, is the most common. TE is for tracheoesophageal abnormalities, R is for renal, and L is for limb abnormalities. So we should actively search out for these abnormalities. So this you can see is a contrast study which tells us about a tracheoesophageal fistula. This tells us about a tracheoesophageal fistula, where you can see that the contrast is going into the trachea as well. So from the esophagus, the contrast is also going into the trachea. This is the contrast going into the trachea as well. So there is a definite fistula which is present in this patient. Now, how do we manage these children who have tracheoesophageal fistulae? So, the management and prognosis depends on the Waterson's criteria. It depends on the Waterson's criteria. And the Waterson's criteria for tracheoesophageal fistulae takes into account two things. It takes into account the birth weight, and it takes into account the presence or absence of pneumonia, whether pneumonia is present or not in these children. Now, if the birth weight is more than 2.5 kgs and there is no pneumonia present in these patients, then these patients can be taken up for upfront surgery. And this is the group which has the best prognosis. The best outcome is also seen in these children. Now, if the birth weight is between 1.8 to 2.5 kgs, and plus minus pneumonia is there, then we will give these patients antibiotics, nutritional support for few days, and then we take them up for surgery. Definitive surgery, which I'll just discuss in some time. And finally, the group which does the worst is children where the birth weight is less than 1.8 kgs and they have pneumonia. So in these patients, what is done is that these patients are not fit candidates to undergo an extensive surgery. So in these patients, we just carry out a gastrostomy, right? We do a gastrostomy for nutrition. And we will carry out a delayed repair when these patients are fit. So delayed repair is done. Of course, to treat the pneumonia, these patients will be given adequate antibiotics. So this is the Waterson's criteria. There are other criteria also which are there, but Waterson's is the most popular one which has been asked in the exam as well. The other criteria which you can remember is known as the Spitz criteria. It is known as the Spitz criteria. You don't need to know the detail, just remember the name. That another criteria is the Spitz criteria. Now, what is the actual surgery which we perform in these patients? So the surgery which is done for type B, C, D and E. So type B, C, D and E, these patients undergo Cameron-Hyat's procedure. These patients undergo Cameron-Hyatt's procedure. Now, what exactly is Cameron-Hyatt's procedure? So, in Cameron-Hyatt's procedure, my first thing is to expose the trachea and the esophagus. And to expose the trachea and the esophagus, I need to carry out a thoracotomy. I need to open up the thorax. And the thoracotomy, which is usually done in these patients, is a posterolateral thoracotomy. So as opposed to thoracic trauma, where I told you we do an anterolateral thoracotomy, here we are doing a posterolateral thoracotomy to expose the trachea and the esophagus. Now, the basic principles of this surgery are, supposing this is the esophagus, which has a fistulous communication. This has a fistulous communication with the trachea. So the first step in this procedure is to take down this fistulous connection. So take down the fistulous connection. We remove the fistulous connection. Remove connection between the trachea and the esophagus. The second thing is we repair the trachea. And to repair the trachea, if you remember the module on sutures and knots, I told you that PDS, polydioxone, which is a synthetic absorbable suture, polydioxone, PDS is used to repair the trachea. Once we've done that, third aspect is to anastomose the two ends of the esophagus. So we anastomose the two ends of the esophagus. And then we are going to close the thoracic cavity. Of course, we put in a chest tube before we close the thoracic cavity. Right, so these are the steps in Cameron-Hyatt's procedure. Now, what about esophageal atresia? Type A is different. Type A is esophageal atresia. What exactly do we carry out in esophageal atresia? So in atresia, there can be two scenarios which you can encounter. Scenario number one is when the two ends of the esophagus are close to each other. Right? The two ends of the esophagus are close to each other. And if the two ends of the esophagus are close to each other, we can carry out anastomosis between the two ends. And this will be a tension-free anastomosis. Because the two ends are close to each other, we can easily anastomose them. And that would be the treatment for these patients. But the problem arises when the two ends are far apart. If the two ends are far apart, then what will happen? Now, if the two ends are far apart, you can see that these two ends are far apart. And if they're far apart, I cannot carry out anastomosis. Why? Because we've already discussed, if they're too far apart and if I do suturing, the suture will just cut through this repair, right? It'll just cut through this repair because of increased tension. So we can't do that. So what exactly do we do when the two ends are far apart? So when the two ends are far apart, what we are going to do is we are going to carry out a gastrostomy for nutrition. We are going to carry out a gastrostomy for nutrition. And we feed this child, and as the child grows, the two ends are going to move close to each other. As the child grows, the two ends move close to each other. And when they are sufficiently close, we anastomose them. We carry out anastomosis. Now, another device which has been approved by the US FDA, and this has been mentioned in the latest Sebastian as well, is the Flourish device. So the Flourish device can also be used for esophageal atresias type A. And what exactly is the Flourish device? Flourish device is when you put magnets on both the ends. And what will happen by putting these magnets? These magnets are going to attract each other and they hasten the growth. The growth between the two ends occurs in a faster manner if these magnets are put or the Flourish device is inserted. Now, final 2 points regarding tracheoesophageal fistulae. These surgeries which we have performed, the most common complication of these surgeries, the most common complication is anastomotic leak. The anastomosis can leak. And the most common long-term complication is a stricture at the anastomotic site. So these 2 points you should remember for the exam as well. And you should know that tracheoesophageal fistulae do carry a high mortality rate. Approximately 40% mortality is seen in these patients with tracheoesophageal fistulae. Despite the best management, there is for 30 to 40% mortality seen in these patients. So this was regarding tracheoesophageal fistulae. Now we'll start with a very, very important and interesting topic known as GERD. So GERD is gastroesophageal reflux disease. And this is interesting because it is a problem which affects a lot of people. In fact, a lot of students who work in medical colleges, and if you have food in the canteens there or the hostel canteen, I'm sure you've suffered from GERD sometime or the other. So this is gastroesophageal reflux disease. Now, first we need to understand what are the factors which help in maintaining the patency of the lower esophageal sphincter. What are the factors which help in maintaining the patency of the lower esophageal sphincter so that reflux does not occur? Right, so this was our esophagus. This was the esophagus. This was the stomach. And this is the diaphragmatic opening. And this is a gastroesophageal junction, which in normal people like us lies in the abdominal cavity. So factor number one, which is responsible for maintaining the patency of the lower esophageal sphincter, is the length of the intra-abdominal esophagus. The length of intra-abdominal esophagus. So the length of this intra-abdominal esophagus, is 3 to 5 centimeters. That is the length of the intra-abdominal esophagus, which helps in maintaining or which helps in keeping the lower esophageal sphincter in the abdominal cavity, right? The second factor is the angle of His. What is the angle of His? That is the gastroesophageal angle. Angle of His is the GE angle, gastroesophageal angle. This also helps in maintaining the patency of the lower esophageal sphincter and keeping it closed. The third factor is the pinching effect of the right diaphragmatic crura. The third factor is the pinching effect of right diaphragmatic crura. Pinching effect of right diaphragmatic crura. And the least contribution is by the arrangement of the gastric mucosal folds, is by arrangement of gastric mucosal folds, right? So these two questions have been asked in the exam. The most important factor is the length of the intra-abdominal esophagus. This has been asked. And the least contribution is by the arrangement of the gastric mucosal folds. These are the factors which prevent reflux. So reflux will occur if the length is less than 2 centimeters, if the length becomes less than 2 centimeters, and if the pressure of the lower esophageal sphincter, and if the pressure becomes less than 6 millimeters of mercury. So again, you need to remember these values: length less than 2 centimeters, pressure less than 6. That is what is going to predispose to GERD. And what happens in GERD is there is increase in the number of transient lower esophageal sphincter relaxations. There is increase in the number of transient lower esophageal sphincter relaxations, and that is the abnormality which leads to GERD in patients. Now, we've discussed about how GERD is occurring. What are the actual clinical features of GERD? So like I told you, GERD is very common, and the most common clinical feature which people encounter is heartburn. It's not the heartburn if somebody swipes on the wrong side on Tinder. That's not the heartburn which I'm talking about. It's a retrosternal burning sensation. It's the burning sensation which you get if you eat spicy food or very hot food. That retrosternal burning sensation is known as heartburn. There can be water brash. Water brash is when suddenly a lot of acid comes into your mouth and you get a very bitter taste in the mouth. That is known as water brash. There can be pharyngitis, laryngitis, dental caries can be there. Some patients can have chronic cough. They can have asthma-like symptoms or chronic cough can be there. Wheezing can be there. So these are the various symptoms with which the patient can present. Now, whenever a patient comes with these features, we don't straight away do investigations, right? We don't carry out investigations. In fact, what is done is that these patients are empirically started on treatment, right? Empirical treatment is started for these patients. And only if they fail on the empirical treatment do we carry out investigations, right? Only if they fail on empirical treatment do we carry out investigations in these patients. So please remember that. And what are the investigations which are done? So the investigation of choice is an upper GI endoscopy. The investigation of choice is an upper GI endoscopy. But the gold standard investigation in these patients is a 24-hour pH monitoring, right? So what is the difference between investigation of choice and gold standard investigation? I've covered this in the breast module as well, but I'll just repeat again. Investigation of choice is the one which is the most feasible investigation, most practical investigation to do, and majority of the times it will tell me about the diagnosis, right? Majority of the times. Whereas gold standard will tell me about the diagnosis 100% times, right? 100%. But it might not be the most practical investigation to carry out, right? Like 24-hour pH monitoring means you have a pH probe sticking out of your mouth for 24 hours, right? That is not practical, not to be done in all patients. So that is why that is the gold standard. But the investigation of choice is endoscopy, and there should be no confusion between these two because both have been asked in the exam. Now, this 24-hour pH monitoring is usually done if we are contemplating surgery, in the patient, or if there are equivocal endoscopy findings. That is when we carry out 24-hour pH monitoring. And in 24-hour pH monitoring, the pH probe, this has been asked in the exam, the pH probe is kept 5 centimeters proximal to the gastroesophageal junction. 5 centimeters proximal to the gastroesophageal junction is where we are going to keep the pH probe. Okay. And what exactly are we measuring? So there is a score which is calculated that is known as the Demister's score. Now, if the Demister score is more than 14.72, then that indicates GERD. Or if the pH is less than 4 for more than 4% time, that will also indicate GERD in patients. Now, like I told you, we can either do conventional 24-hour pH monitoring, or there is a wireless probe as well. And this wireless probe is called the Bravo 24 probe. This is a wireless probe which can be used to measure the pH inside the esophagus. Now, one thing which you need to remember that before we do the 24-hour pH monitoring, we should stop proton pump inhibitors and prokinetic agents. For at least 5 to 10 days. Before we should start the PPIs, we should stop the PPIs of prokinetic agents. Otherwise, we can get a false value when we do the 24-hour pH monitoring. Now, how exactly do we manage these patients? Like I told you that initially when these patients come to us, we carry out empirical treatment. And what is the empirical treatment? So empirical treatment entails lifestyle changes. And what are the lifestyle changes? And these, I think so, all MBBS graduates should know, because GERD is such a common problem that no matter what kind of doctor you become, your relatives or your friends would definitely ask you about GERD and its management. So lifestyle changes would be weight reduction if the patient is overweight. Weight reduction should be done. Then these patients should be told to avoid certain food items. And what are these food items? Well, these are the food items which everyone likes. And I think so for a medical student who's preparing for the PG entrance exam, this is their staple diet. So this includes fried food, fatty food like chips, fried food, fatty food, spicy food, which you get in your canteens, right? Mint, chocolates, citrus fruits, so lemon water, nimbu pani, all those things will increase GERD. So these are the things which you tell the patient to avoid, because they relax the lower esophageal sphincter and they can worsen GERD. These food items can relax the lower esophageal sphincter and they can worsen GERD. These patients should be told to take small frequent meals. They should be told to take small frequent meals. And very importantly, that dinner should be at least 2 hours, at least 2 hours before going off to sleep, at least 2 hours before sleeping. This is very important. And there is no role of putting more pillows. So, if you talk to your parents or your elderly people at your home, they will say just put more pillows and this GERD will stop. Well, adequate research has shown that no matter how many pillows you put, that is not going to prevent GERD. Okay. So these are the lifestyle changes which we recommend for these patients. In addition to this, we give these patients medicines. And what are the meds which are given? They are given proton pump inhibitors and prokinetic agents. And I'm sure as interns or as MBBS students, you have asked medical representatives for these PPI samples. I know for a fact that when we were postgraduates, we used to do that very frequently, because having food at odd hours, having, spicy fried food, all of us used to suffer from GERD, and we used to ask the MRs for just these PPI samples so that, we could take them and get through our duties. Now, there are certain patients where we need to carry out surgery as well. And what are the indications for surgery in these patients with GERD? So, patients not responding to medical management, right? Those who are not responding to medical management. Patients suffering from complications of GERD. And what are the complications of GERD? Well, we'll talk about Barrett's esophagus, which is a very important complication. There can be strictures which can develop, or cancer. So, if these complications are there, then also surgery has to be carried out. If GERD is associated with a large hiatal hernia, hiatal hernias I'll talk about later, and they can be associated with that, and then also we need to carry out a surgery. And a patient who was well controlled on medicines, but now the patient wishes to give up medicines, and these patients will also require surgery. So because they were well controlled on medicines, when they give up on their medicines, and their symptoms are going to come back, right? So you will have to carry out surgery in these patients. So these are the indications to carry out surgery. And the surgery which is done for these patients is called fundoplication. So what are the principles of fundoplication? The principles are, well, we know that there should be adequate intra-abdominal length. And what happens is that if the intra-abdominal length reduces, the gastroesophageal junction moves into the thoracic cavity and reflux starts. So the first step is to restore adequate intra-abdominal length. We have to restore adequate intra-abdominal length. It should be more than 2 centimeters. So at least 3 centimeters length we need to achieve here. The second step is to tighten the diaphragmatic crura. We tighten the diaphragmatic crura around the esophagus so that reflux does not occur. The third step is to wrap the fundus of the stomach around the esophagus. And if you see the movement of my hand, this movement of wrapping around the fundus around the esophagus, this is very similar to how we shine our shoes in the morning. So this is known as the shoe shine maneuver. This wrapping of fundus around the esophagus is known as the shoe shine maneuver, and this has been asked in the exam. And I will show an operative video where this will be demonstrated. We have to save the vagus nerve and we have to re-establish the angle of His. So these are the principles of surgery: to restore adequate length, to tighten the diaphragmatic crura, to wrap the fundus around the esophagus. This I told you is the shoe shine maneuver, which has been asked in the exam. To preserve the vagus and to re-establish the angle of His. Now, the types of fundoplication, the most common fundoplication is a total fundoplication, that is a complete wrap. Nissen's is a complete wrap. This is 360-degree wrap. This is a complete wrap or a 360-degree wrap. Now, the problem with Nissen's fundoplication is that this is a complete wrap. So, because of this, the most common early complication The most common early complication is pneumothorax, and this can occur because we are doing this surgery laparoscopically. We do this surgery laparoscopically, and through the hiatus, gas can escape out into the pleural space, and the most common intraoperative complication can be pneumothorax. But the most common overall complication of Nissen's fundoplication, this has been asked, the most common overall complication is gas bloat syndrome. And what is gas bloat syndrome? Well, gas bloat syndrome is that if you are doing a 360-degree wrap, the wrap is so tight that the patient cannot even burp. Even gas cannot come up, right? So the patient will complain as if, they can't even burp normally. So that is known as gas bloat syndrome. And because of this gas bloat syndrome, therefore we carry out partial wraps. Therefore we do partial wraps, or we do floppy Nissen's fundoplication. We do a loose Nissen's fundoplication so that gas bloat syndromes don't develop. Now, the partial wraps which you should know about are Dore, which is a 180-degree anterior wrap. You can have Toupet, which is 180 to 270-degree posterior wrap, and Belsay-Mark procedure, which is a 270-degree anterior wraps. So these are the partial wraps which can be carried out as well, or partial fundoplications which can be done as well. Now, fundoplication is usually done laparoscopically, and 4 to 5 ports are used to carry out fundoplication. Now, you can see this short operative clip where I've demonstrated the key steps of fundoplication. So this is a video of fundoplication, and this was shared by Dr. Pankaj, who is Dr. Sakshi's husband. He's a laparoscopic surgeon. So he had shared this video, and here you can see that first the liver retractor is being put into place so that we can get adequate exposure, and then we are going to start dissecting out the lower half or the abdominal part of the esophagus. So you can see here, this is the attachments are being freed, and we are going to expose the diaphragmatic opening and the lower part of the esophagus. So you can see the attachments are being freed up. So now the attachments are being freed up, and we've reached the diaphragmatic hiatus. You can see the cardiac pulsations as well. So this is the diaphragm, and you can see how the diaphragmatic hiatus is being opened up. The lower part of the esophagus is being dissected, so that then we can wrap the stomach around it, and we can also tighten the diaphragmatic hiatus again. So you can see the crurae of the diaphragmatic opening which are there, and the esophagus is being freed up. Okay. You can see that with laparoscopy you get great amount of magnification, and that is one of the advantages of minimally invasive surgery, which I've also highlighted in the minimally invasive surgery module. So you can see here now the esophagus is very well dissected, and then once we've done that, the fundus is going to be mobilized, and it is going to be taken all around the esophagus. It's going to be wrapped around the esophagus. So now you can see that the diaphragmatic hiatus is being tightened, and you can tighten this using Prolene suture. So that Prolene suture is in place, and the hiatal opening would be repaired so that again the esophagus does not move up. And we know if the esophagus moves up, then there's going to be reflux again. Okay, and one of the main principles of fundoplication is that we have to bring down the esophagus. We have to recreate the intra-abdominal length of esophagus, right? We have to tighten the hiatal opening, and we have to wrap the fundus around the esophagus. Those are the key steps of fundoplication. So this is the hiatus being tightened. And now you can see that the fundus of the stomach is being wrapped around the esophagus. And before we do this, there is a shoe shine maneuver, and that has been asked multiple times in the exam, that you should easily be able to mobilize the fundus around the esophagus. And this maneuver which you do before you start wrapping the fundus around is known as the shoe shine maneuver. So this you can see that the fundus is being wrapped around the esophagus. The hiatus has already been tightened, and this will then complete our fundoplication. And we know that we have to minimum achieve a length of 3 centimeters of intra-abdominal esophagus. That is what we want to achieve, minimum 3 centimeters length of the intra-abdominal esophagus. So these are the fundoplication stitches which are being taken, and this is our complete fundoplication which has taken place now, and this is the completed repair at the end. So you can see in this diagrammatic representation of how fundoplication is done. This is Nissen's fundoplication, a complete wrap where you can see a 360-degree wrap has been done around the esophagus. So this is a 360-degree wrap, right? This one is a diagram of the toupee repair, which is 180 to 270-degree wrap around the esophagus, right? Another surgery is Colles gastroplasty. Colles gastroplasty is done when there is esophageal shortening. So in patients with GERD, some patients can have fibrosis of the esophagus and there can be esophageal shortening as well. And to increase the length of the esophagus, we carry out a Colles gastroplasty. Where we fire a stapler, a linear stapler I've shown you in the module on sutures and suturing techniques. So we fire a linear stapler and we create an adequate length of the esophagus. A neo-esophagus is created so that we get adequate intra-abdominal length. So this surgery has also been mentioned in both Bailey and Sebastian. So you should know about Colles gastroplasty as well. Now, GERD, there are other newer modalities also which are being tried out in these patients, which are less invasive than to carry out a fundoplication. One of the modalities is to inject polymers around the lower esophageal sphincter. But they've seen that these injections of polymers are associated with a very high recurrence rate and they are not preferred. So, injection of polymers have a high recurrence rate and they are not preferred. The line which is written in Bailey and in the latest Sebastian, which is very important, endoscopic RFA. RFA is radio frequency ablation. This is the technique which has shown long-term results. Good long-term results have been seen with endoscopic radio frequency ablation. These endoscopic techniques also later on, there is a risk of stricture formation in these patients in the long run, but endoscopic RFA is the technique with good long-term results. Another technique is known as the LINX device, also known as magnetic sphincter augmentation. This is the term which is written in Sebastian, magnetic sphincter augmentation. So this can be done in patients with minimal or no hiatal hernia, and you can just put magnets around the lower esophageal sphincter and they can keep the lower esophageal sphincter shut, right? So this is known as magnetic sphincter augmentation. Another very interesting surgery which is mentioned in the latest edition of Sebastian is transoral incision-less fundoplication. And there was a trial which was done which was known as the TEMPO trial, where this transoral incision-less surgery was done and it has shown good long-term results. So this transoral surgery is an example of a NOTES procedure. NOTES I've covered in minimally invasive surgery is natural orifice, transluminal endoscopic surgery. So we go through the oral cavity in the form of an endoscopy, and from inside only I will carry out the fundoplication. So what is the advantage? You don't need to do laparoscopy. You don't need to make incisions on the outside. So this is an example of a NOTES procedure, and this is a NOTES surgery which is being done for GERD, known as transoral incision-less fundoplication. So these were the various modalities to take care of gastroesophageal reflux disease. Now, one of the most important complications of gastroesophageal reflux disease is known as Barrett's esophagus. And Barrett's esophagus, by definition, is a metaplasia of squamous to columnar epithelium, and this is also known as specialized intestinal metaplasia. So this is very important, specialized intestinal metaplasia, and this can be seen in patients with long-term GERD, that this metaplasia can occur. And the significance of Barrett's is that this can increase the risk of adenocarcinoma. It can increase the risk of adenocarcinoma of the esophagus. So the pathognomic finding in Barrett's esophagus is the presence of goblet cells in the lining, and I'll show you a slide later on where these goblet cells are clearly seen. Now, the clinical features of Barrett's esophagus are very similar to those of GERD. So the clinical features of Barrett's are similar to GERD, but it can also have a silent presentation. So the patient might still have Barrett's esophagus, but might not be expressing a lot of symptoms of GERD as well. So silent presentations have also been seen. And Barrett's esophagus, how do we make the diagnosis of Barrett's esophagus? So the diagnosis of Barrett's esophagus is made by endoscopic biopsy, right? And what do we see during endoscopy? So we see the typical red velvety mucosa. You will see a typical red velvety mucosa of Barrett's esophagus, and that's where you know where to take the biopsy from. Now there are three types of Barrett's esophagus. Which are there. You have a long segment Barrett's esophagus. Which is more than 3 centimeters. You have a short segment Barrett's esophagus, which is less than 3 centimeters. And you have cardia metaplasia. Which is microscopic. Barrett's. Right. Now, when you encounter a long segment or a short segment Barrett's esophagus, you know where to take the biopsy from, right? Because you will see this abnormal mucosa. You will see the red velvety mucosa, and you know where to take the biopsy from. But the problem arises when there is cardia metaplasia or when this red velvety mucosa is not typically seen. So if the abnormal mucosa is not visualized, then what we carry out is, what we do is known as chromoendoscopy. Where for Barrett's esophagus, we use methylene blue. So we stain the esophagus with methylene blue, and whatever altered blue areas we can see on endoscopy, those are the abnormal areas, and we need to take biopsy from there. Now, this is very similar to what Dr. Sakshi has taught you in cervix. In cervix, if you cannot see the abnormal epithelium, you stain the cervix with acetic acid, and you take the biopsy from which areas? Correct, the aceto-white areas. Similarly, here we stain the esophagus with methylene blue, and the abnormal bluish areas, we take the biopsy from there, and we will see the goblet cells. So this is chromoendoscopy. Another technique is called narrow band imaging. Narrow band imaging can also help us in identifying this abnormal mucosa. This has been written in Sebastian. So the types of Barrett's I've already told you. This is how we do the biopsies. When we do biopsies, we do it at 1 centimeter distance. So in Barrett's, how do we do the biopsy? They are done at 1 centimeter distance. So we take adequate biopsies from all quadrants at 1 centimeter distance. And on the histological slide, you will see goblet cells. So these are the goblet cells. You can see the goblet cells. These are the goblet cells which we can see, and they are pathognomic of Barrett's esophagus. This is chromoendoscopy, where I told you for Barrett's and adenocarcinoma, we will use methylene blue. But for squamous carcinoma, we can use Lugol's iodine. Lugol's iodine can be used for squamous cell carcinoma to identify small abnormal areas of squamous cell carcinoma. So this is chromoendoscopy. Around 5 years back, there were 2 questions which were asked in the All India exam regarding chromoendoscopy. So what we've discussed is what is Barrett's, what are the types of Barrett's, how do we diagnose Barrett's. Now, how do we manage Barrett's esophagus? So Barrett's esophagus is managed according to the Seattle Protocol. And this has been asked in the exam. So the Seattle Protocol is that these patients with Barrett's esophagus, they are put on a 2-yearly endoscopic surveillance protocol. And whenever we do this 2-yearly endoscopic surveillance protocol, we will carry out multiple biopsies, which I've told you. Now, when we do these multiple biopsies, what are the various outcomes which we can get? So, number one, we can again get Barrett's esophagus. And if we get Barrett's, we continue the same protocol. Right? Second, we can get a low-grade dysplasia. So after metaplasia, Dr. Ila has taught you after metaplasia, you can have dysplasia. So there can be low-grade dysplasia. Now, whenever dysplasia develops in Barrett's esophagus, what we first have to do is we have to ablate the abnormal mucosa. We have to ablate or destroy the abnormal mucosa. And to ablate or destroy the abnormal mucosa, the options which are available to us are radiofrequency ablation. RFA is radiofrequency ablation, or you have PDT, that is photodynamic therapy, is there. It has been seen that radiofrequency ablation is better than photodynamic therapy, or APC, that is argon beam photocoagulation. And less stricture rates have been seen with RFA, and in RFA 12 joules per centimeter square is the energy which is imparted, and there are less stricture rates in RFA as compared to photodynamic therapy or APC. So this is how we ablate the abnormal mucosa. Now, once abnormal mucosa has developed, it is common sense. Will you still do 2-yearly endoscopies, or do you want to reduce the time gap? Of course, we want to reduce the time gap, because if there is some abnormality happening, we want to detect it early. So now these patients with low-grade dysplasia are called for 6-monthly endoscopies. So if there's low-grade dysplasia, they will come for 6-monthly endoscopy. Please remember this point. Okay. Now, patients who have high-grade dysplasia, the third possibility can be high-grade dysplasia. Again, if there's high-grade dysplasia, you have to ablate the abnormal mucosa. We have to ablate the abnormal mucosa, which we've discussed is better with RFA. Ablate abnormal mucosa. And now we are going to call these patients every 3-monthly, right? So 3-monthly endoscopies are to be done. So 3-monthly endoscopies have to be done in these patients, as opposed to 6-monthly for low-grade dysplasia. And the final possibility can be that these patients can develop cancer. And if these patients develop cancer, then the only option available with us is esophagectomy. Okay. Now, there is one peculiar thing which has been mentioned in Sebastian, which I want you to know, especially for the INI CET exam and the SS exam. So what happens is that, supposing this is the lining which is there, this is the abnormal lining which has your Barrett's changes. So this yellow one is the Barrett's changes. Now, when I do RFA, supposing I've done RFA here, RFA has been done, and when we do RFA, this lining is shed off, right? This lining is shed off. And when this lining gets shed off, what happens? That new squamous epithelium will develop. But sometimes what happens, that this small amount of these Barrett's changes, this small yellow is left behind. And this yellow gets buried. This yellow Barrett's can get buried below the new epithelium. It can get buried below the new epithelium. So these are known as buried glands. These are known as buried glands, and cancer can sometimes develop in these buried glands. And you need to imagine that if cancer develops in these buried glands, it can be missed because on top of it, you have normal squamous epithelium coming up, right? So that's how sometimes cancer can get missed after these ablative techniques due to these buried glands. So this was the management of Barrett's esophagus, which is one of the most common complications which you need to know for GERD. The other complications for GERD are stricture formation and cancer. Cancer is the one which I'm going to talk about in the next module. Now, as we've been doing for all modules, for final year students in this module, what is important? For final year students, very, very important is Barrett's esophagus. Asked as a short note, very commonly, Barrett's esophagus is asked. GERD is a short note which is asked in the college exams as well. So you should know about Barrett's and GERD from this module. Let's solve a few questions before we move on to the next module where we'll talk about esophageal cancer. So the first question is, a baby is playing unsupervised and complains of difficulty in swallowing since the last few hours. So this was asked in the INI CET exam and they've given the hint in the question stem itself. There's difficulty in swallowing. So I told you most likely it's in the esophagus. And X-ray is done. We can see the X-ray has been done. And if you look carefully, you can see the gas shadow in front. You can see gas shadow in front. And the coin is behind the gas shadow. So the coin is in the esophagus. And you can see endoscopic removal of that coin is being done. So foreign body in the esophagus is the correct answer. Two mischievous children playing with each other. One swallows a button battery, the other one swallows a coin. Right? So we know button batteries, what will be the management even if the patient is asymptomatic? Correct. Endoscopic removal. And his friend who has swallowed a coin, the coin is found to be impacted at the pharyngoesophageal junction. Coin is impacted at the pharyngoesophageal junction. And if it is impacted at the pharyngoesophageal junction, again we have to carry out endoscopic removal. Which of the following statements is not true regarding corrosive esophageal injuries? Alkali injuries are most severe. This we've discussed is a true statement. Acids cause more gastric damage due to pylorospasm. This is also a true statement. Endoscopy should be delayed for a few days. This is false. I told you early skilled endoscopy needs to be done. Early skilled endoscopy needs to be done. Prophylactic antibiotics have not shown to improve survival. This is true. Which of the following statements is not true regarding tracheoesophageal fistulae? Proximal end blind ending and the distal end communicating with the trachea is the most common. So I told you about the types of tracheoesophageal fistulae which are there, and in this question they have written about type C, which is proximal end blind ending and distal end communicating with the trachea. That is the most common. This is type C. This is the most common. Flourish device can be used for type A. This is true. This is used for atresia. Watterson's criteria takes into account birth weight and pneumonia. This is true. And anterolateral thoracotomy is done. This is false. We carry out a posterolateral thoracotomy. A 5-day-old child with excessive drooling of saliva undergoes a contrast study. Image is shown below. Child weighs 2.6 kgs. What is the best management? So you can see in this contrast study that this contrast study depicts a tracheoesophageal fistula. This depicts a tracheoesophageal fistula. And for tracheoesophageal fistulas, if the weight is more than 2.5 kgs, then we will take these patients up for definitive surgery. So that is the correct answer here. We'll take up this patient for definitive surgery. Which of the following is not true regarding the management of GERD? Endoscopic radiofrequency ablation has shown good long-term results. This is true. Lynx device uses magnetic beads around the lower esophageal sphincter. This is true. Gas bloat syndrome is the most common overall complication for fundoplication. This is true. And minimum 1.5 centimeter intra-abdominal length should be achieved. No, minimum, it should be more than 2 centimeters length should be achieved. So this is a false statement. The procedure shown, this I've told you, is Coley's gastroplasty, which increases the length of the esophagus. So this is a very important question according to me. Here you have to tell me all of these patients are good candidates for anti-reflux surgery except. So you have a 31-year-old male who has typical GERD with disease becoming resistant to medical therapy. So if the disease is resistant to medical therapy, of course, this patient is a good candidate for surgery. You have a 55-year-old lady with disease well controlled on proton pump inhibitors. But now she wishes to discontinue medical therapy because somebody has told her that long-term PPIs can cause gastric cancer. So now she wants to leave medical therapy. Now, if she leaves medical therapy, will her symptoms come back? Obviously. So we have to carry out surgery in this patient as well. A 75-year-old male with new onset heartburn, weight loss, which is not relieved by PPIs. Are these features of reflux? Well, 75-year-old, first time in his life getting reflux with weight loss, more suggestive of cancer, and we will not carry out anti-reflux surgery in this patient. A 52-year-old man with volume reflux and large paraesophageal hernia, this is true. A 56-year-old CEO is diagnosed with Barrett's esophagus after a long history of GERD. He visits you to understand the disease. All of the following statements are correct except he requires 2-yearly endoscopic protocol. Correct. This is known as the Seattle protocol. If high-grade dysplasia is detected, esophagectomy should be done. No, we should do 3 monthly endoscopies and we should ablate the abnormal mucosa. For high-grade dysplasia, no esophagectomy. In low-grade dysplasia, endoscopy should be reduced to 6 monthly scopies with ablation of abnormal mucosa. This is true. Lifestyle changes should be recommended to this patient in addition to control drugs to controlling reflux. Absolutely. So you have to offer them lifestyle changes as well, which I've already covered while talking about the management of GERD. So these were some important MCQs regarding this module. In the next module, we'll talk about esophageal cancers. Thank you.